Hi, good evening, everyone. Welcome back to our webinar, which is always on a Wednesday, 9 p.m. And today on a follow-up of our last webinar, which was on plastic surgery by Dr. Margaret Liao, we were talking about burns. And today we're going to talk about reconstructive surgery, with Dr. Jeffrey Chan. Dr. Jeffrey is the latest of our plastic surgeon to join Sunway Medical Center. And I think he has a vast experience. He was previously in UK. Maybe you'd like to introduce yourself, Jeffrey?
Hi, good evening. I'm Jeffrey Chan. I have joined Sunway Medical Center maybe for 1.5 years, just under
Has
one.
it been 1.5 years? Wow.
Yeah.
Time passed very fast, huh?
Yes.
Okay.
So previously in the UK, I was consultant in Guy's and St. Thomas. For 1 year, I was doing hand surgery. And after that, I was still in Guy's and St. Thomas, but I also worked in King's College Hospital in London, in Denmark Hill, in the major trauma center. So we do a lot of like a major trauma, mostly lower limb, but also upper limb. So we're responsible for tissue coverage of major like arms and legs with skin loss. Previously, I was trained in Ireland. So my training was quite broad in different fields such as skin cancer surgery, burns, breast reconstruction, etc. So today I will show you like a selection of cases of the broad range of things that a plastic surgeon can do. So should I share my slides?
Yeah, sure. Go ahead.
All right. Can you see?
Yeah. You put it on slideshow?
Okay.
Okay, great.
So the content of this talk is mainly to introduce to you what a plastic surgeon, or more accurately, what a reconstructive surgeon can do and can contribute to your patients. How to go forward.
Yes, that's right.
So you can see that in this diagram, most people in Malaysia, we think plastic surgeons only do cosmetic surgery or aesthetic surgery. But we also do things like scar management, burn surgery, cleft surgery, skin cancer. These are the main things that I think Malaysian doctors will realize we do. But on top of that, we also do breast reconstruction, head and neck reconstruction, such as tongue cancer, jaw cancer. We do chest wall reconstruction, upper and lower limb reconstruction, including lymphedema, and also sometimes perineal reconstruction. So today you see a selection of cases, what we do. So first of all, what is reconstructive surgery? Reconstructive surgery mainly concerned with the repair or replacement of physical defects that can consist of either skin, muscle, bone, fascia, and sometimes tendon of periosteum. So we work on damaged structures such as in the hand, in the face, upper and lower limb, the breast, the trunk, and also external genitalia. We have skills in the use of surgery that involves using grafts such as bone graft, skin grafts, flaps, as well as we transfer tissue from one part of the body to another with the use of microsurgery. We can also do replantation of, let's say, a finger or a hand. So microsurgery is part of plastic surgery. And I'm not sure why that in hand surgery, they call it hand and microsurgery, because other specialty also use the microscope, such as ophthalmology, ENT, and neurosurgery. So I don't know why they...
Okay, we shall not get into the politics of, territorial marking by some people, but we shall go on with the purpose of this talk.
So I want to concentrate on the scope of what we do as a reconstructive surgeon. So I show some cases, some are simple, some are challenging. But these cases, some are already simplified for the purpose of this talk. So I heard that Margaret was doing a burn talk yesterday, so I won't go too long on this. So this kid come in with a friction burn to the fingers and palm. So after dressing it for about 2 weeks and a half, it didn't heal.
How
But
did he burn in a treadmill machine? You mean he was put his hand onto the
from the rollers,
conveyor belt?
yeah, the rollers.
Oh my God. How old is this kid?
I think it's about 1.5.
Oh, I see. Wow, that's quite dangerous, huh?
Yes.
Okay. So
So
we learn also that do keep away the kids from your all these
machineries.
yeah, machines and whatnot. Okay, go on.
So this didn't heal with a conventional dressing after about 2.5 weeks. So I proceeded to skin graft this. As you can see, the middle ring finger has been skin grafted and the index finger itself just left to heal on its own.
And this skin graft is actually from
The groin.
the groin.
Yes.
And the skin looks so thin that it doesn't look like it will look normal back, is it? Or it will look
Like
as
this.
if it's
It will look a bit pigmented because this is not glabrous skin. This is normal skin. The palm has glabrous skin, so it's a bit thicker and highly keratinized. But you cannot find a donor site with a lot of, like a large area of glabrous skin to replace the finger. So you have to use a regular skin from like your trunk or your groin.
Can I ask you one question?
Yes.
What if the tip of the fingers were involved and you have to graft it? Then what will happen to the fingerprints?
There will be no fingerprints.
There will be no fingerprints, right?
Yes.
So then how do we use devices these days, or even let's say biometric?
That's a good question, but I have no idea. You can actually insert fingerprint if you take a free flap or a flap from the toe and put it on the tip. But
Oh,
it's a bit more complicated.
I see. It's
And
very important
the
question,
original fingerprint.
because you see so many of our devices now use our fingerprint. Even doors are use fingerprints, or let's say, yeah. Okay.
So anyway, this two fingers were skin grafted. You can see they're fairly straight, no problem, no contracture. But the finger
Yes.
that wasn't skin grafted, even though it healed, has a contracture here. So it's very important to realize this and to perform skin graft if you need to do skin graft. That's my message.
Oh, yes.
And
I
this
can
one
see
won't last very long because the kid is growing. So this will continue to pull in.
Can you operate and reduce the contracture?
Yes, but later on. Now we will be just doing scalp massage and stretching exercises. Hopefully this hand or this finger will last a bit longer before we proceed to skin graft or release the scar.
Okay.
So this patient, another patient, this is a middle-aged lady who came in with a very infected finger. This is her first presentation for diabetes. Her HbA1c was like 16 when she came in. So she had this puncture injury approximately 2 weeks prior to her admission. And you can see there's an abscess on the back of her hand, in the palm, on the volar side, the index finger and the middle finger. So I tried to save this finger, drain all the abscesses. You can see all the incisions.
Oh my God.
But we couldn't save the finger because the vessels were already thrombosed. So eventually we have to amputate this and also control the sepsis at the same time. So eventually we managed to control the sepsis, and you can see before that the skin on the middle finger also missing from the infection, necrose. So I used the skin that is present here. I hope you can see the pointer.
Can.
And that piece of skin is used to cover the middle finger here. And
Oh,
the carpal was shortened to give you a wider web space. So
oh, it looks almost normal.
yes. So this piece of skin actually from the index finger, although it's sitting on the middle finger. So this is now about approximately 3 months old. 3 months after the surgery, the hand is still stiff, but you can see it's improving from month to month. And if you just glance at it, you wouldn't realize she has a finger amputation. If it's done well, just like Homer Simpson. She has.
Oh, he has only 4 fingers plus the thumb. I
Yes,
never noticed that.
yes, exactly.
But can the middle finger, oh, when you show the middle finger, then it won't look so middle fingerish, right? But can the middle finger act like this when
Yeah, you can. You can oppose
fine
the thumb.
when you do fine work, fine movement, you can still use the middle finger like the uh the second finger, right? What is it called? The pointing finger,
Index finger.
index finger.
Yeah,
So
actually, this lady actually already doing housework. You can see there's a little black mark here. This is actually a new injury, a burn.
oh my God.
Her finger was stiff, so she hold the pot and didn't, couldn't hold it properly and caused like a blister here.
Okay.
Move
Oh,
on.
I never noticed that Homer has only 4 fingers, 3 fingers and a thumb.
Sounds like that's a message of the day.
Yes. Okay. Go on.
This is a picture of post-op surgery. Can you see the scar? I don't know whether your connection is good or not. Can you see the picture properly? Can you
Yes,
find
I see the picture properly, but cannot see the scar is not so obvious.
So this is after a basal cell carcinoma excision of the lower eyelid. You can see this process here. So this is a BCC on the left-hand corner here with like a central ulceration and a lesion around it. So I did a excision with a 2 millimeter margin and we do a local flap. So the skin from here was actually pulled from the lateral side into the defect. And you can see the healing process, and eventually after a few months, you can barely see the scar. It's actually here. Can you see that?
Yeah, no, it's not obvious at all. If you don't point it out, even when you point it out, it looks almost exactly like the right eye.
Okay. So this girl has a very horrific road traffic accident with orbital fracture. I'm sure you can see the scar on the eyebrow here, the lateral canthus here, and the nasal labial fold.
Okay, there was previously lah.
This is after surgery.
Okay.
Previously, she looked like this. So, so for injury like this, you can try to hide the scar. This one can be hidden in the eyebrow. This one can be hidden in the nasal labial fold. This one can be hidden like around the eye. And for a scar that is shallow like this can be easily hidden by like a foundation or something. So it's not too bad.
Yes.
For injury that she gets.
Wow.
So plastic surgeon also remove lumps and bumps. So this is a lipoma, very large on the shoulder of this young girl. She's been keeping this for, I don't know, a few years. And eventually decided to come. So I removed this with a few incision for a 10 cm lipoma. So this is the scar after 10 days or so. So there's another lesion. This is a bony lesion in the forehead. Can you see this?
Yes. This is very common, right?
Yes, this is very common. So she's a young girl, and after discussing with her, giving her the option whether she wants a direct scar on the forehead or something more hidden, she decided for something more hidden. So you can see that after surgery, you cannot see the scar on the face.
How do you do it?
Like go through the hairline. You can see stitches here.
Oh, I see. To be honest, it's easier if she has a bangs, like fringe. Cut her hair short at the front, and then it would hide her high forehead and also the bump, the lump without surgery. But you can't see the scar at all. Yeah. Okay.
So this lady has some kind of neurosurgery. So the problem with Malaysian patients is they come and say they have neurosurgery, but you don't really know what was the previous surgery. But you can see there's an indentation here. There's some kind of
yes.
bone flap of the skull being done. And then she actually had weakness of her eyebrow.
Yes.
You can see her weakness, but you cannot go up, but you can go down. Can you see that?
Yes.
Play that again. So the problem she has is actually,
Is it a ptosis? Is it a ptosis?
yeah, it's a ptosis of the eyebrow and also the forehead on the left side. Can see her problem actually is, can see the
Yes.
covering the eye. So this is her complaint actually. So it's like something blocking her vision. So what I did was I just did a very simple brow lift directly. You see that when you lift the eyebrow, the eye opens up. So this is just 1 week. This is a photo of 1 week after surgery. You can see the sky is still fresh.
Mm-hmm.
In the hairline of the brow. And her eye has opened up. Even the eye looks slightly bigger than the left side. The right side.
It's quite symmetrical. It's very good. Yeah. Yes. Very nice.
So this is another case.
Oh my God.
You might want to close your eyes if you can't. You just have dinner.
Okay.
So this is a case of a very unfortunate elective gynae surgery. I don't know what it was. I think it was like a cyst surgery or ovarian cyst surgery or bladder surgery or something like that for incontinence.
Oh my God.
Surgeon punctured the bowel and then caused sepsis, intra-abdominal sepsis, and the intra-abdominal sepsis spread externally into the cutaneous tissue, and she actually had necrotizing fasciitis. And you can see that the surgeon has fashioned a stoma on the abdominal wall, which is the wrong thing to do, because this piece of skin actually need to go. See the underneath the tissue is all green and necrous. Can you see that? So these are the resected specimen. And actually what we did was we have to remove the whole abdominal wall on the front and some of the lower thoracic.
So there is no skin at all.
There's no skin, and also this part actually has no muscle, this part.
Oh
And
my
this part has
God.
muscle, and the surgeon has no choice but to put the stoma on the left side here where there's some muscle left. So this is a stoma bag. And this is abdomen. There's no abdominal wall. Underneath this is directly on the omentum. So this is a very horrific necrotizing fasciitis.
Okay. Oh my God.
So you can see the stoma here is leaking onto the whole wound. There's a problem with sepsis. This is a plastic bag we put over the omentum to prevent the feces from going into the abdomen, into the abdominal cavity itself. And then we have a problem of securing. You see, we're trying to put urinary catheter, try to drain the feces, but it's all leaking through. So what we did was we tried to find a way to stick on the stoma bag. So first thing we do was we put on the skin graft just on this area. You can see that after a while, the skin graft dries up, and you can stick the sticky stoma bag there to control the feces from leaking everywhere. And after that, only the whole area clean up and granulated. This took about maybe 6 weeks or so. She was in ICU for that long or longer.
It only took 6 weeks. Oh, for the granulation tissue to form. She survived.
She survived, yeah, went home.
Wow. How old is the patient?
60 plus. And then eventually, this is the skin graft. This is the first check of the skin graft, still very fresh. After that, she went home.
Oh my God.
Yes.
Do you have a picture of where her skin has really grown?
No, I don't have.
Okay.
I have another case actually in Sunway, but not as bad. But that one involved her breast. I had to do a breast reduction because it was part of her breast necrosis.
And it's because of
Similar complication from the intra-abdominal perforation spread to the externally to the skin, and then spread up the chest, spread under the skin onto the breast and onto the thigh.
wow. Okay.
But let's move on.
Yes, let's move on.
And this little benign looking thing is actually a sarcoma. It's called a dermatofibrosarcoma protuberans. Generally speaking, it doesn't spread to other location except in rare cases, but there's a high risk of local recurrence. So normally when we do this kind of surgery, we have to cut around a very big margin, usually like 3 cm around the lesion. Even though this lesion is maybe 1.5 cm, you have to cut 3 cm, 3 cm from the lesion to your cut to reduce local recurrence. So to do this, you to close the wound, you actually have to do a local flap or some kind of or skin graft. I prefer local flap because I think it's thicker and it's nicer. The color is better. So you cut around here. You maintain the blood vessel here so that this piece of skin is alive, and you flip it on, so it becomes this way. This one you just close directly, and then after a few weeks, this thing flattened. Obviously, the tummy tissue is fatter than the back tissue, so it's still a bit bumpy, but it's better than a skin graft, in my opinion. So this is this patient. So this is a local flap and also called a perforated flap, because we base the skin is perfused on a small perforated blood vessel. I see your picture change.
Oh, because I want to drink water. So I want to drink water, so I don't want to the sound.
Well, I said I also work in the major trauma center in London. So this is one example of a wound breakdown after open fracture. And this patient you can see has a circular frame to support the fracture. So the problem with a lower limb fracture like this with soft tissue stripping and periosteal stripping is that there's risk of non-union, delayed union, and osteomyelitis. And patient can lose their limb, can end up with amputation. So in overseas, we are very aggressive with this. This is another case. You can see there's an ankle fracture with the tibia here. The screw is put on the distal tibia, and this is a skin defect. This is a fairly old patient, so we didn't do anything too aggressive. But the principle is to fix and flap, which means you have to fix the fracture, and also you have to cover the skin defect with a tissue flap. So in this example, I choose to do a local flap, also known as a perforator flap or a propeller flap. You can see that the fracture and the skin defect is here. We take a piece of skin from the adjacent area. And this piece of skin actually is rotated into the defect. So this tip is actually distal. So you can see we raise this flap with the blood vessel still attached. And then the tip of the flap then used to cover the fracture site and the metal. And then this raw area here, which consists of muscle at the base of the wound, can be skin grafted. So you can see this is a propeller-like thing because it's being turned around to the defect. So you can see here, just to show you, the blood vessel is still attached to the piece of tissue, where the entire surrounding area and the base of the flap is being skeletonized. So then the skin here originally was up here. So we close part of the wound and the rest of the wound, which has muscle underneath, with skin graft.
Wow. How long will it take to do this?
This one take maybe two hours or so, because we have to operate around the frame. You have to put your hands in the frame, in the holes in the frame to
I see.
do the operation. So it's not easy. They already put the frame before the orthopedic surgeon call you, so you have no choice.
Yes, I get it. So it looks like you always clean up people's work, lah.
Yeah, sort of.
Sometimes, most times. Okay.
So this is another case of a salvage surgery. Like you said, this is a 14-year-old girl crushed by a gate and then have this very crushed fingertip. You can see the bone, right? This is the drawing. The bone is in many pieces. I just put a few Kirschner wires. And then all this pulp tissue, the nail, all being crushed, unhealthy. So because she's 14-year-old, I didn't want to amputate. In a usual situation, we would have amputated it probably just above the PIPJ joint, just above the second joint. But because she's only 14-year-old, I wanted to try harder. So I put the finger in the groin. So we raise a piece of tissue from the abdomen and we park the finger. You like park the finger in this piece of
Where
tissue.
exactly is this, the anatomy of this
Show you
groin?
here.
Oh, okay.
So we park it here for 3 weeks so that this piece of skin actually picks up the blood supply from the finger.
So she's like having an umbilical cord to her groin.
Not here. Yeah, she's stuck.
It's like a cord lah. It's like joint. She can't pick. She
She
can't
can't.
lift, she can't lift it up, right? For 3 weeks.
No, you cannot. It's permanently stitched on for 3 weeks. And after that, you divide the flap. So you cut it off here so that this piece of skin now is the tummy skin, become the finger skin.
Oh, this one definitely got no fingerprint lah.
Yeah, no, you want to have a fingerprint.
Yes.
Then initially you cannot really make it too tidy because this piece of skin is still like surviving on the finger, just like capillary perfusion of the finger. So you leave it big, leave it like a blob first. And then once it's a bit more stabilized, then you slowly thin it out to the shape of the finger. So this debulking and refashioning of the finger. So I end up like this. Like I said, no finger, no print now, unfortunately.
Print, yeah.
The point is you keep the length of the finger.
Oh, so this is
Otherwise, you have amputated here from the beginning.
but she has a toenail, no, fingernails.
She got a little bit of fingernail. It's a bit atrophic now because the nail tissue is ischemic or partially necrosed from the first injury, from the injury.
But it's almost normal.
Yes, that's the point I'm trying to make.
Yeah, amazing.
With the finger. Okay, you get the idea?
Yes, I get. I'm amazed. I'm impressed actually. Oh, very nice. Okay.
So now we go on to deglowing injury. So deglowing injury when you have the overlying skin and subcutaneous tissue shear over the deep layer, such as the muscle. So you end up with this space, free space here that can form hematoma, whatever. So I'll give you one example here. This man was climbing up the jambu tree, fell down. So strip off this piece of skin. So this is open deglowing because the whole thing is open. You can open up, flip it up like this, like a door. So this is the periosteum for the skull. Okay. And it's not easy. Just close it up, wash it up, stitch it up. So this is another case. This guy have a road traffic accident. So unfortunately, the A&E officer put the patient on spinal board because there was a question about spinal injury. So the patient wanted to go to toilet, couldn't go to toilet. He defecated on the spinal board. And
I can't see. Okay, go on.
you cannot see where.
I mean, as in, I can't look at it. Okay, go on, go on.
He has a wound next to his anus. So when he defecated, the feces or the bacteria went into this hole.
Oh my God, okay.
And at the same time, he got this big deglowing of the thigh. So this piece of subcutaneous tissue is actually separated from the underlying muscle. So there's a potential dead space here. So the bacteria spread from the perianal area into the thigh, down to the knee. So it's almost like a necrotizing fasciitis, but it's not because it's spreading from the anus, spreading from the perianal area through the potential space. You get the idea?
Yes, I get the idea. So on the left hand side where the skin is,
Reddish cellulitis and abscess in there.
oh, I see. From the infection that's from the
infection, the feces, the bacteria spread from this wound. Because there's a freeway from here. Because this whole skin is lifted from the thigh.
Okay, can I ask you, you made a point about the spinal board. Okay, if it has not been a spinal board, is there a relationship between this?
Like for him, a commode or something
I see. As in, if they didn't have to worry that the patient had spinal injury and the patient had gone to a commode or toilet, this would not have happened.
And that's likely to happen because this is he's shitting on his buttock. There's a wound there.
And I see. Okay.
And the spinal board actually is not for patient to sit on. It's only for transfer. If you have a spinal injury, you can rest the patient on the bed. You don't need to lie the patient on the spinal board until everything is over.
Okay.
It's pressure sore.
Okay.
So anyway, this is the abscess that we had to open up. So you can see there's a big hole here in the buttock.
Okay.
And this whole area here we have to open because there's pus and bacteria, everything, necrotic tissue, the fat. Then we open everything up, drain it, IV antibiotics. And we know that inside here, there's a big tissue loss. You can put your fist in there actually. The hole is that big. So to speed up the healing, we actually raise a flap. I raise a gracilis flap here. This piece of muscle actually still connected up here. There's a blood vessel to perfuse this piece of muscle. Then we flip it down to obliterate the dead space here.
Okay, Jeff, I want to ask you a question. When I do angiograms, they are really like bread and butter. They're almost always quite similar. There may be a few cases that's more complex than others, but your cases can be anything.
Yes. So anyway, that's why we know about perforated flaps. We know the blood vessel. We know the muscle, each muscle, what blood supply comes, where the blood supply go into, etc., etc. Because we need to sometimes borrow this kind of muscle or tissue to reconstruct. So
Okay.
this is a muscle is used to close off the defect in the perianal area. Because otherwise this cavity will take a long time to heal. So we
Okay.
close up everything. And this thing heals maybe in like 2-3 weeks. See,
So
this is,
you put in the muscle and then you sew it up.
yes.
Could you not just sew it up?
So
Like,
yeah, the dead space, so it's gonna keep getting infected. Bacteria will
oh,
still be in there. You want to remove the dead space.
okay.
So this is another example. This is a cancer case, abdominal perineal resection of the anus here, right? Hello.
Yeah, I'm here.
Okay. So you can see the skin and the anus and the rectum and the mesorectum, all this been removed. There's a dead space also in there in the pelvis, right? Sometimes this has been pre-radiotherapy, or sometimes they need post-op radiotherapy. So there's a high risk of wound breakdown. So to reduce this, we actually also do the similar thing like the previous case. We will raise a piece of skin here with the muscle. And this piece of skin we'll use to cover the anus where it used to be. And there's also muscle in there.
So what happens to the anus then? You have to do a colostomy.
Patient have colostomy. This is done by the GI surgeon, not by me.
Yes, that's right.
Is responsible for closing the defect. So because the muscle is also quite small and the dead space is quite big, we have to use two muscle. So you can see on the left thigh here, there's a second muscle being raised and put in there. So two gracilis muscle are used to stuff into the dead space. And one side, you also take it with the skin to close the anus defect.
The take-home message today that I really feel, I never knew that dead space is so important to cover up dead spaces with
Very important because is a space for collection. It's like pneumonia. You have pleural effusion. You want to
get rid of it.
Yes, you want to get rid of it because it's a place where all this stuff grows, the bacteria,
And I
sepsis.
never knew that it's so difficult to get rid of dead spaces.
And this one is also to help with radiotherapy because if you just stitch up tightly under tension this piece of skin here, you just close it edge to edge without the piece of skin in the middle is under tension. So it's risk of strangulation of the wound edges, wound breakdown, necrosis. Then your radiotherapy, the area is going to break down.
Okay.
Okay. So now we go into the next thing, which is microsurgery. You can see this is a fracture again, tibia fracture with a skin loss, and there's necrosis of the skin edges. So routinely in the UK, we will do a free flap and metal work at the same time. So we call this fix and flap just for short, like the one I showed you earlier on. And this one is using tissue from another place and is transferred into the defect fracture site. So in this case, we use the skin from the thigh. here. You can see this is a flap called the anterior lateral thigh flap being raised. Okay, sorry.
Okay.
Hold on. Trying to start the video. Right here.
Okay.
You can see that this is the piece of skin that we wanted with the blood vessel we raised into the source vessel here. So this piece of this is another view actually. This is the blood vessel. And this blood vessel is going to be disconnected here. So we chop it off here. The whole thing transferred down to the leg. So this is a piece from the thigh. And the blood vessel run underneath. And then here we do microvascular surgery, which is we reconnect the artery and the vein. They're usually about 1 to 2 mm. So we need the microscope. So after it's done, this piece of skin is alive. Blood will run into it and blood will be drained by the vein that we reconnected. So it's a healthy piece of tissue. So it avoids like tissue wound breakdown. It provides a healthy layer over the fracture site so that the fracture site can heal with less risk of sepsis. Do you get that?
Yes, I get it.
So this is another case. I actually did this case with Dr. Margaret. So I think she's in the audience.
Yes.
So this patient is actually a retired orthopedic surgeon. He came in with this drawing. Came in with this drawing and said, "Can you please raise this flap and turn it down to cover the defect on the ankle?"
He's trying to teach you.
Yes. So I told Dr. Margaret, no, I don't want to do this because if you do this, you're going to cause an incision from the heel down up to the lower part of the leg. So going across the ankle is a big hole, a big incision. And then if any part of the wound break down, then you're going to have a
amputation.
No, you're going to have a big hole, big like wound breakdown. And then also this scar is going across the ankle. So you're going to have a stiff ankle, reduced range of motion.
This wound is caused by poor circulation.
No, this one is caused by previous Achilles tendon repair. So the orthopedic surgeon, which is his colleague, did the Achilles tendon repair. His Achilles tendon was ruptured. So the
wound looks so dirty.
And the wound broke down. The wound didn't heal, it broke down. So I end up with a hole like this. So that's why I come to Dr. Margaret and say, "Can you please raise this piece of skin and turn it down to cover my defect?" Then Dr. Margaret asked me and said, "No, I don't want to do this." So I gave him a few options. And then eventually we settled down on a small flap from his forearm. So this is a flap of skin in the middle side of your upper forearm. You can see this flap has been raised. There's a perforator vessel. This vessel actually comes from the ulnar artery. So we chop it off just before the ulnar artery. So this is a branch of the ulnar artery, not the ulnar artery itself. So we don't sacrifice a big vessel. We just take the branch of the ulnar artery. You can see this is the 10 by 10 piece of gauze. So this is a very small flap, and this is the artery and vein coming here with the clamps ready to be transferred to the heel. So then we transfer the piece of skin to cover the defect. Of course, we debrided it, make sure it's clean. He's on IV antibiotics. Wound swab has been tested for bacteria. And then the blood vessel run under the skin here, and we reconnected it into the posterior tibial artery and vein under the microscope.
Wow.
So this is probably the smallest free flap we ever done in Sunway Medical Center. Very small. So this guy has been gone on holidays, gone to China, traveling, hiking, etc., and came back. He came back and asked me to do his trigger finger.
Okay. Can I ask you, when you take the flap from the hand, there is no problem to this piece. Why is that so?
No problem to what?
To where you take the flap from.
You just close this directly.
You close it with what?
Stitches.
Why because it's not a free space. It's
No, this is loose. You will squeeze your side of the thing. It's loose, right? It's no tension.
I see. Okay.
It's unlikely to cause any problem.
Okay.
It's like when you remove a big mole in the forearm. It's exactly like that. You just close it directly.
Sorry, I don't have any experience with plastic surgery. as
That's
a
what-
doctor or even as a client, as a patient. So I don't know. Okay, go on. Let's go on.
So that's his result. Okay, I showed that already. So next, this is a boy from Indonesia came in to me with this big tumor. It's actually a low-grade osteosarcoma, which we realized later. But you can see that the CT scan, this is a reconstructed 3D CT scan. The whole jaw here is destroyed from the tumor. Can compare to the right side is normal, a lot of bone, and here this is destroyed. So what we do, we take also take a free flap, but this free flap consists of skin, bone, and bone. Okay, you can see this is the lateral part of the leg, this is the fibula. So we raise the bone, take the bone with a piece of skin, and we take the blood vessel also. So the idea is that this piece of skin is to cover the buccal area, the mucosa layer of the inside the mouth. This piece of fibula has been broken into two because we need the break to make the angle of the jaw. You can see we're ready with the wires to do the osteosynthesis. And you can also see here there's a plate ready to go. This is a blood vessel which we reconnect to the neck or to the face. So this result after 13 months, I only saw this boy again last week actually. You can see this part here. You can see this is the normal jaw, right? It's normal jaw. This part is the fibula. You can see that.
Yes. Oh, the fibula.
Yes, the leg. And this is the TMJ joint. We kept the TMJ joint, but we the rest of the jaw from there down to like the premolar we remove. So this is after 1 year. He suffered a bit of a facial palsy from retraction because he's such a young kid, but it's maybe like 80%, 90% settled down. And after a while, you can see he's have good mouth opening, maybe 4 cm.
And you managed to clear the board, I mean margins and all?
Actually, when we performed this case, we didn't know it was a sarcoma because the pathology from Indonesia said it's benign.
I see.
So we were in a shock when the local pathologist in Malaysia told us this possibly a sarcoma, and then it was sent to a second opinion, and then it was proven to be a low-grade sarcoma. And this boy had a oncology
Referral.
yes, and they decided there's no need for any chemotherapy, just like regular PET scan. And so far, after 13 months, there's nothing there.
Okay.
There's no found. So he's lucky, and we're still monitoring. So you're asking me how's his leg. So this is his leg. There's a patch of skin graft here because we took the skin. So I put a skin graft here, so it looks different color. But he's back. He's gone to he's playing badminton, so no issue.
Amazing.
So next on we move on to breast reconstruction. So in Malaysia, anyway, in Sunway we don't get much breast reconstruction cases. I don't know why that is, but where I used to practice, we routinely get breast reconstruction cases.
Why
Meaning-
we don't have it's quite common these days. But now it's also common for breast surgeons to not do mastectomy but do lumpectomy with in early cases. So maybe that's why.
the breast surgeon do their own reconstruction in Malaysia, if I understand
Oh
correctly.
no. Where I practice in Beacon, we call in the plastic surgeons.
Okay.
Yeah.
It's not in Sunway, by the way. So this is one example. This is a breast pocket after mastectomy. So the role of the surgeon, the plastic surgeon, is to fill this pocket with tissues or implant. So I'll give you one example. This is a paper I published in my previous job. So this patient had a right mastectomy, including the NAC, nipple areolar complex. And we decided to put 2 free flaps, one from each abdomen. Okay. This is a free flap where we harvest the artery and the vein. One flap we put inside. It's almost like an implant, but it's a tissue implant, your own fat. And the second piece of tissue we put on top to give it the bulk. And we also take a small circle of the abdominal skin to make the areola. And then the tummy defect here, you just close it off like a tummy tuck. You can see here that patient get a free tummy tuck, flat tummy. The tissue here in the right breast is entirely of the abdominal fat and a small circle of abdominal skin. Can you see that?
Yes.
So the benefit of doing a free flap or autologous flap reconstruction is that it's entirely 100% the patient's own tissue. There's no silicone implant, meaning there'll be no revision, there'll be no scar contracture, there'll be no the breast shape changing shape over time. The abdominal wall are mostly preserved. There's less risk of bulging, weakness, hernia formation. The breast also can grow. If the patient gets fatter, the breast will get bigger. If the patient loses weight, the breast will get smaller. And the reconstructed breast feels like a normal breast because it is actually abdominal fat inside. And if the patient needs radiotherapy, this is also been proven to be resilient to wound breakdown or other complication from radiotherapy. So we cannot have your abdominal tissue to reconstruct to be transferred to your breast for breast reconstruction. We also can also take tissue from your thigh, medial thigh. Can take tissue from your flank. Can take tissue from your upper buttock or lower buttock. So it depends on the patient body shape. Many options can be chosen. So next we go on to hand again. This is a very straightforward amputation of the thumb by electrical saw injury. So in replantation, you not only have to fix the bone, you also fix the arteries, the veins, the nerves, the tendons, flexor and extensor tendons. So in this case, you can see that the joint, the IPJ joint has been destroyed from the saw. So what I did was I just fused the distal phalanx onto the proximal phalanx to make it into one, insert the flex position here. So what you want to do is to have a stable thumb so that people can, the patient can oppose and have a functional hand. So next is another case, but this is more complicated. This is a younger patient, 21-year-old, also an electrical saw injury, amputated his index finger and the middle finger. So the index finger actually very straightforward. You just replant it back, no issue. But you can see the middle finger here, although it's only a partial amputation. You can see the PIPJ joint, the saw has gone through the PIPJ joint. So the PIPJ joint is destroyed. And this will cause your finger to not be able to fully straighten or fully make a fist. It becomes stiff. So in a young patient, how do you replace the joint? You cannot really put a artificial joint there because it will probably last you 5 years. So in a 21-year-old, maybe he'll need like 10 operations for the rest of his life. And every time it's getting worse and worse. So I counsel him for a toe transfer using the PIPG joint of the second toe. You can see this second toe has been opened up. I take the joint, a bit of skin, the tendon, and the blood vessel.
So the toe is gone.
Toe is gone. No, I put the joint of the finger into the toe.
Oh,
the toe
because it's not so important.
Yeah, the second toe doesn't need to flex. You can still function. So I put the bone from the finger into the toe, just like a bone graft.
I see. So
I take the joint here and make the finger.
Fixed, it's
yeah, it becomes
it's like fixed.
Straight toe. Yeah.
Yes, fixed second toe. Oh,
So
okay.
So this is what we call a free vascularized joint transfer. So it's vascularized because we take the artery and the vein. These are reconnected back in the finger or in the hand. So this piece of tissue is actually not a graft, it's a flap. It's a vascularized piece of tissue. Once you've done the connections of the artery and vein successfully, this bone is bleeding, is alive. Understand? Like the skin.
Yes, yes, understand.
Okay. So I can see here in the X-ray, right? From here to here is the toe, but in the hand, in the finger.
I see.
And from here to here is the toe with the joint here. And this, of course, is a bit bulky. We do the connection here, the vein, and the other side, we do the artery. And this is the...
Ask you, you
Yes.
know when the finger is, or any digits or anything that is amputated and they bring it along. Okay.
Yes.
People, anybody can bring it along, passerby to the hospital. How long will it before it's not, I mean, how long can it last?
If it's preserved properly, let's say a finger, which does not contain muscle, can last for, of course, you should bring it in as soon as possible, but it can last for like 12 hours,
Oh,
even
I
more.
see.
But ideally, you want to do it as soon as possible, because the longer you wait, the more like you will not hold, you're not keeping it properly, it can become dehydrated. The thing can start thrombose inside the small veins and artery, and start thrombose. Infection sets
Okay.
in, so we become like...
Okay, I mean, it's not likely, but let's say for all of us who are ignorant, if we do see a case like that, how do we keep it, like preserve whatever stump that we bring along? How do, let's say a GP, what does he need to do?
So you wrap the piece of amputated part in a wet gauze, saline wet gauze, then you put it in the sterile container. Okay.
Okay.
And then this sterile container should be put into a cold environment, such as a plastic bag with ice and water.
Okay.
So you're recreating a fridge, not a frozen, a fridge, like 4 degrees.
Okay,
The
thereabout lah. I mean,
plastic bag must have ice, must have water and ice.
Okay.
Yeah, not only ice, because the ice will cause freezing of the piece of tissue. Once it's frozen, the cells will burst, and then the
It's
replantation,
like frostbite like that, yeah.
then it won't work. So it must be cold, but not frozen. If not cold, then you just bring it warm, and the hospital hopefully will do it for you properly. But
Just that we don't know how long the duration will be before. Okay.
yeah, as soon as possible. But if the piece of tissue contains muscle, then you have to be fast, because it won't work if you replant it, say, after 6 hours. So,
Okay. So if it's like a leg, definitely before 6 hours now.
but actually, to be theoretically correct, the piece of limb that is replanted with the muscle on must be replanted at 6 hours. That means the circulation must be established in the operating room
Okay.
6 hours or 8 hours,
Okay.
not reaching the hospital at 6 hours, because by the time
Okay, I understand.
So this finger, anyway, this is index finger, no simple replantation, nothing. This is the joint, the middle finger, can make a full fist.
Oh,
And see that?
yeah. But cannot open straight, is it?
It's a short of full extension, because the toe joint doesn't have have like a 180 degrees of flexion from full straightening to full extension to flexion. So you have to put the bone slightly in flexion, so that the patient can fully close, and you accept that he cannot fully extend by a little bit. So it depends on the toe. Some toes are very flexible. You can have a lot of range of motion, but for this patient, it's not so. So you lose a bit.
Your job really needs you to think on your feet very quickly, most times. Of course, like let's say it's tumor or what, you can plan, but if it's
you can plan. This is not done straight away. This is done few months.
Okay.
The toe joint, because I actually told him in the beginning, I said, I want to do a toe joint for you. He couldn't accept it. Obviously, when you tell somebody, I want to take your toe and put it in your hand, they can't accept it. You have to, they will suffer from the pain and the stiffness and the suffering. Then only they agree.
Okay. So some are planned, yeah. Okay.
Some of these are planned. Yeah, most of these are planned. So this is another horrible injury. This is a
Oh,
forearm that's being crushed by another.
Facebook is going to ban me already because they already warned me.
Okay.
Okay, so I have to, I'm going to stop the Facebook live stream, huh?
Okay.
Okay, bye-bye. Bye, guys, the live stream, okay?
So, you're ready?
So there's a forearm that's been crushed. You can see this is the radius.
Yes.
So in multiple pieces, I move on. So then we have to temporize this. We put a temporary plate. We debrided the whole thing. You can see all the extensor tendon of the forearm has been divided from the trauma.
Yes.
And then we just dress this in the, let me say like we plan this, we just temporize this with a temporary plate, we dress this with a vacuum dressing, and then the next stage we plan for reconstruction. So in this case, you can see we raise two flaps, two pieces of two skin paddle from the thigh. Okay. We also take tendon from the thigh, the tendon fascia lata from the thigh. So we make it into strips and we reconstructed the fingers and the wrist extensor tendon with a small piece of the flexor tendon of the wrist. And then the skin paddle is used to, then after, when we do the tendon, we have to do the tensioning. So we have to test the tension. Okay. Otherwise, it's too loose, you won't
So when
extend.
you take the tendon from the leg doesn't, you don't have to worry about the donor?
Tensor
Like-
fascia lata. Tensor fascia lata is a long, flat, big, white, flat piece of and a very thick tendon. It's not
Really
sure.
essential.
Yeah, it's better to be done.
Okay, I understand now.
And
Okay.
you have to sacrifice something to reconstruct another part. So you can see that the two skin paddle that I talk about is here and here. So one for the front of the forearm, one for the back of the forearm. And then for the back of the forearm, if you look closely here, I also split this into two. So this is like a pita bread. You can see it's split into two. One consists of skin and fat, and the other layer consists of fat only. And you can see I put this piece of fat under the tendon to protect the tendon from contact from the metal and from the bone. You see that? So it produces like a gliding layer so that the tendon does not get stuck onto the fracture site or onto the metalwork. And of course, like the previous case, we also reconnect the artery and vein.
So sorry, my dogs were fighting.
Okay.
Okay.
So then, of course, he's very stiff in the beginning, all swollen up, very little range of motion. This is done actually during COVID times. So after about a year, you can see this is him.
Well, he's a very fit, muscular looking guy, huh?
Yeah.
Was it
Full function.
motor vehicle accident?
Yeah, it is. This guy here, this guy.
Yeah, that's right. That's right. I know.
So he has full extension, despite these are all tendon grafts. You can see the fingers can go straight, fully straight, and the wrist can go fully straight.
It's not disappointing. This is an amazing recovery. You see what I mean?
And then this is him, supination and pronation, full extension.
Wow.
It's a very nice reconstruction because you almost thought he just have a few scars on his forearm, but you don't know the amount of work being done underneath.
Yes, I cannot imagine.
And this is his scar because we took quite a big skin paddle, so the scar stretches, but it's acceptable for injury. You either have a bad scar or no forearm. So you will remember the picture.
Yes.
Most people will have amputated this. They won't even try to reconstruct. So for him to have this kind of function, I think is a very good result.
It's extremely good.
Thank you. So what about bone? Can we replace bone? Of course, you saw the fibula, but this one is a radius fracture and ulnar fracture. The ulnar are just being plated because there's no bone loss, but you can see here in multiple pieces here. So this bone, if you just put a plate on, they'll get into non-union or infected non-union or delayed union. So what did we do? We took a fibula. So we took a fibula, right, and we use it to replace part of the radius. You see, like the jaw just now, this is a fibula, blood vessel, skin paddle. So the fibula is being inserted into the radius. The artery and vein is being reconnected. The skin is being used to cover the skin defect, and the plate is being used to hold the whole thing together. You can see this is the fibula. This is the fracture site which has healed like in about 3 months. And the second fracture site is here. You hardly can see it. Here
What
has a
tattoo your name there also.
Huh?
Tattoo your name there, Jeffrey Chan. It's the least you could do.
Suffer a bit of a hypertrophic scar, but I think it's okay.
Hold on, I need to scold my dog.
Okay.
Go on.
So this is his donor site. Because we took the piece of skin, we had to skin graft his leg, but he's walking. You can see wearing shoes, walking. He's actually a semi-professional boxer. You can see him on YouTube. So he's back, gone training for boxing again.
So this is where you took the fibula.
Yes,
The fibula, you take part of it only, right?
that's part of it. We maintain the distal 8 cm to make sure the ankle is functioning well. So we go from 8 cm above.
And you take part of it, doesn't it? Will it not be weak enough to, let's say, have a fracture or something?
What?
The fibula.
You don't need a fibula in the leg.
You don't need.
You just need the distal 8 cm to maintain the ankles in the mosis and ankle function. So
Oh, wow, interesting. Okay.
so this is his range of motion. He actually have bilateral forearm fractures. The one with the fibula actually is recovering faster than the fibula, which is like amazing.
Yeah, it's cool. No,
Yeah.
you see the movement of the hands is really amazing.
Okay. So next, I hope we have enough time.
Okay, how many slides do you have left?
Maybe 10 more.
Oh, 10 more. We don't have more. 10 more. We need to invite you back for another talk then.
Nearly done. You want me to continue what? Yes.
Okay, we continue as much as we can. Come, go on.
Of small defect, this guy has been treated for paronychia for like many years because they thought it's just a paronychia near blood infection, but it's actually a cyst in there. You see the cyst has destroyed the bone.
Oh,
So
yes.
the cyst in there, okay? The bone is a hole there, so it goes straight into the other side. So there's a small defect. So what do? I harvest a small flap from the wrist. So this is the wrist. This is the skin paddle. This is the branch of the radial artery. Not the radial artery, the branch, which is like 0.7 mm size, and a vein I harvested. So I reconnected the artery and the vein and this piece of skin to cover the defect behind the nail. And I make a scratch here. You can see blood is bleeding straight away. So this piece of skin is alive. So after like, I can't remember now, maybe like 1 year, you can hardly see the scar here where I took the skin from. And here is where the skin from the wrist has healed very well onto the back of the nail. There's no nail, unfortunately. You have to.
But what happened to the bone that has been
I
eaten
put
up with the
some
cyst?
artificial bone graft into the defect.
Oh, I see. Okay.
So that's a big thing about lymphedema. So everybody knows about lymphedema, and everybody knows that the treatment is conservative, but not many people know that there's surgery that you can do for lymphedema. So you can see that lymphedema has many stages. You can progress from very mild to very severe. And in very, very severe cases, you can get infection, recurrent cellulitis, thickening of the skin, fibrosis, difficulty in walking, activity of daily living. And sometimes you can also get sarcoma of the limb, lymphangiosarcoma. So the early stages is reversible and the later stages are non-reversible, because the reversible part is where it's fluid predominant, where there's mostly fluid that causes the swelling. But if you don't treat this, it will progress to fibrosis. And when there's fibrosis, there will be, you cannot reduce the size of the leg or size of the arm. So the message is to have your treatment early. You get it? So this is just an anatomical specimen. The lymphatic vessel has been stained blue, you can see here. And this one here, the lymphatic vessel has been stained orange. And this is actually a lymph node with all the lymphatic vessel going to the lymph node. And this is
How do you stain it, huh?
an anatomical study. I can't remember the name of the dye. It's like something iron or something.
And
But
how do you, I mean, how do you inject it, or do you
put here, see the blue.
open it up and start staining there?
No, you inject the skin, then you will travel along the
Oh, you
lymphatic.
inject the skin, okay.
And see, this one is on the skin. Also, there's lymphatic on the skin itself. Okay.
Oh, I see so many new things, man. Okay.
So we're actually running a program of screening, ICG screening for lymphedema in Sunway, only 1050. So these are for patients, let's say post-cancer patient, post-trauma patient, post-radiotherapy patient, or those who have a swollen leg or swollen arm with no cause identified. Maybe they'll benefit for this. That's all I'm going to say about this. So this is one example. The patient has been injected with this fluorescent ICG indocyanine green dye into the leg. You can see here on the right leg, the dye is spreading a little bit. Then it travels to the lymphatic channels. These are the blue and the orangey thing you saw on the anatomical slide.
So this is a normal one.
This is fairly normal, yeah. So it travels up the leg, up the thigh, and then eventually end up in the lymph node. So this right leg has functional lymphatics vessels. Whereas the left leg, you can see when you inject it, after a while, it just flood the whole leg. That means the dye are not being transported via the vessels, not being transported by the
Lymphatic.
It's just being like flooding the leg. It's just spreading into the tissues. That's why you see like a big green blob here. Okay. So what can we do? So for the early stages, you can do what we call lymphatic venous bypass. What that means is that under the microscope, you go and find the lymphatic duct. See this? Half a mm. And you go and find a small vein of approximately the same size. Because you know that the lymphatic ducts are not draining upwards. You can disconnect the lymphatic duct and you connect it onto the vein. So you're bypassing the lymphatic drainage. You're using the venous drainage to drain your lymphatic fluid. So you can see here it's being disconnected here. The lymphatic is actually draining from the lymphatic duct into a vein and back to your heart.
I mean, it may sound very stupid, but I don't think it's a stupid question. This lymphatic fluid, what does it compose of?
Yes.
Yes. What is what is flowing through the lymphatic system? Can you hear me?
Composed of, yeah, you're broken up a bit.
Okay, sorry. What is it actually, does the lymphatic the fluid, what is it made of? What is it consist?
It's like it consists of protein, immune cells, water, etc. But if it's spread into your leg, it can actually stimulate like an inflammatory reaction. That's why patients who have prolonged lymphedema, they can get fibrosis. There's a very active inflammation going on, become chronic.
Okay, so you actually do a bypass and then the lymphatic fluid will go through the vein.
Yes, exactly. Because in the thorax here, so it goes into the vein. We're just doing it in the leg.
Okay. We go on.
Okay. So there's other procedures you can do, but the lymphovenous bypass is by far the easiest for the early stages, because you can do like vascularized lymph node transfer, trying to bring in some immune function into the leg. For those, let's say, have recurrent cellulitis, some people do lymphatic vessel transfer. Some people do connect lymphatic vessel into lymph node in the groin. And these are for early procedures for stage 1, stage 0, stage 1. these are called physiological procedures because you're trying to reconstruct or maintain the lymphatic vessel function. But if it's already into fibrosis and sclerosis and thickening, you cannot maintain the tissue anymore. So you need to do excisional or resectional tissue, such as liposuction, such as modified Charles procedure, where you excise everything except you excise everything down to muscle, and then you skin graft right on top of muscle.
Wow. Because this is a very important topic, and it's important because we see a lot of breast cancer patients, and a lot of them survive breast cancer, but they end up with very painful, upper limb swelling of the side that of breast cancer, and it's never easy to treat this lymphedema of the limb. So I think it's a really good thing if we can offer them this. Okay, we go on.
Yeah, and then, so in summary, as you can see, we offer, we can play an important role in the, in many specialties. And also I've shown you that many things that you thought plastic surgeons don't do, we do. So sometimes we do a multidisciplinary approach, such as working with orthopedic surgeon, working with ENT surgeon for head and neck cancers. I've shown you some very challenging cancer cases, injury cases, and some cases you have to curative and for the operations needed and what tissue you need to bring in to plan the operation. So that's what make it very interesting, and that's why I'm doing this. Thank you very much.
Thank you very much. The make it up as you go along is what I've been asking you the whole time. Like, you have to think on your feet all the time, especially in trauma. Okay, we do have some questions. Yes, we are running a bit late, but I think we can take some questions. Let's see. Okay, question one. All the questions are from Dr. T. And question one, Dr. John Mark asked, what strategies can be employed to optimize post-operative care and rehabilitation for reconstructive surgery patients, ensuring not only physical recovery, but addressing emotional and social aspect as a holistic approach to patient well-being? Can you hear me? My line is frozen, is it?
Frozen, yeah. Sorry. What did you
Okay.
say? Was that a question?
Yes, there was a question. Dr. John Mark from Doquity asked, what strategies can be employed to optimize post-operative care and rehabilitation for reconstructive surgery patients, ensuring not only physical recovery, but addressing emotional and social aspect of the holistic approach to patients' well-being? That's a very important question, because if we look at the trauma and the things that the pictures that you've shown us, even as a doctor, I am taken aback. Can you imagine if the patients have to live with it, especially you see that patient with a necrotizing fasciitis of the abdomen? I mean, it's how does she live with it for so long and not be traumatized? I cannot. So yeah, I'm sure you have a multidisciplinary team. Yeah, maybe you can explain further.
Well, like you said, the necrotizing fasciitis is acute. It's not a thing that they live for a long time, but it's the consequences that they have to live for a long time. So normally we have, like, in the hospital itself, we have physiotherapies, occupational therapies, managing different aspects of the care, nursing, and then certain hospitals we have psychologists or counselors also to help them.
Yeah, because really, honestly, it takes such a long time to heal, and you have no certainty whether you will heal or not. Okay, so Dr. Susie Salvania from Doquity asked, In what ways can the integration of cutting-edge technologies such as 3D printing and virtual reality contribute to improved planning, precision, and outcome in reconstructive surgery? That's very amazing, this question. This 3D printing, it can print just about anything.
So 3D printing has been used actually for something like jaw reconstruction.
Mhm.
For example, when you do like a jaw reconstruction, you can actually pre-print where do you want to cut the fibula, what angle, how do you, where do you want to put the screw hole, where do you want to put the plate, how do you set it up, how do you saw the jaw, and then how do you saw the fibula, so everything fit and match perfectly.
But you can't use the 3D printing product to do it, right?
You do you print the jig to
To visualize it better?
no, to put your saw. Let's say your saw want to cut in this angle.
I
The 3D printing has
see.
the slot where your saw go exactly, so that you don't have to think or you don't have to plan. It's already been pre-planned before surgery by you with the computer and with the programmer with the computer.
So do you work with this kind of 3D printing and
I'm,
virtual reality?
I'm not so much experience with it because this costs money for patient. But I visited a place in Belgium which actually invented one of the earlier software called Materialize in Belgium. So they invented the software and I spoke to the scientist. He was teaching me what he does in the lab. So the CT scan actually, CT scan, let's say you're doing a jaw, right?
Uh-huh.
The CT scan of the tumor will be sent to the scientist. The CT scan of the fibula will be sent to the scientist. So they will then decide how much margin they want to cut on the jaw, and they will design a jig with the saw slot on
It's
the
not an easy
on
thing
the leg.
because I'm sure there is no two patients of you that are alike. Even if they got a jaw tumor, those two tumors cannot be the same size.
So yes, so you plan for every single patient.
Yes.
It's not like a default template. Everybody is
Yeah.
different. So the CT scan will be sent to the lab. The leg fibula scan will be sent to the lab. They'll decide which part, how long the fibula you want to saw, what angle, where do you want to put the screw hole, where do you want to put the plate. All this has been done. So when you go to operation room, you're just like a technician. You know the slot. You just put the slot in your cut.
I
You know.
see.
Yeah.
Okay, Dr. Francis asks, is it suitable for post-mastectomy lymph edema? But this question is not, I think he's talking about your surgery for this bypass. Yes.
And it's
That's
suitable for early stages.
yes, for early stages, before the fibrosis set in. So
Yeah.
when we say early stages means, so this will be people who, the oncologists will be the people who are best to pick up early stages and refer.
Most oncologists and most surgeons wouldn't know there's surgery to.
Yes, I didn't know also.
Even I visited Japan, they would operate on patient even almost preventively. So patient who had, let's say, breast cancer, have mastectomy, after surgery, they might not have swelling at all. They might just have some heaviness or some tiredness at the end of the day. But when they do the investigation, there'll be lymphedema and leakage of the fluid or delay in drainage of the fluid in the lymphatic vessel. And they will also do this surgery to improve drainage. So they're going into the prophylactic kind of territory. While in Malaysia, we don't even treat the one who really has.
Yes.
So we're really behind.
I've seen very bad severe ones. Can I ask you, when you do this bypass, right? How many of these bypasses must you do for it to relieve any symptoms?
Generally, there's two school of thoughts. Some surgeons will do as many as possible. But I also met surgeons who will do 3 or 4 in different locations where the leakage is. So it depends on which school of thoughts you follow. But I think you should at least do like 3 or 4 of these connections.
Yeah, because sometimes it can be so huge that I don't think but then if you go in and do 3 or 4 and it doesn't drain enough, it's also defeat the purpose.
It takes time. Even if you've done the surgery, it takes time for the limb swelling to come down. It won't be like tomorrow. You'll be like few weeks or few months later. So you need to manage patient expectation. It's not like a magic bullet where you do it and then tomorrow your limb is back to normal size. It's not like that.
Yeah. Okay. I think we will end here. Thank you very much. It was a very enlightening talk. And maybe you can show us more cases as you collect them next year. It's very nice. Actually, it's very interesting because we will never see it, we will never think about it. And also the thoughts that you have to put in on how to make do. It's like a make do, right? It's like a DIY kind of thing.
Feel like
And
that, yeah.
it's very interesting. I find that very interesting. Okay, I'm going to stop recording.